Hello, everyone. I assume we're live now. Welcome to the Improving Population Health theme meeting. My name is Ben Barr. I'm a professor in public health and lead the Improving Population Health theme. Can we move on to the next slide, please, Sharon? Yeah, so just a reminder of what the Improving Population Health theme is all about. We're working with members across the northwest coast, looking to expand effective local public health action, particularly on the determinants of health and health inequalities. So that's some of the things like, could be things like employment or housing or some of the social factors that influence people's health. And we're looking at building capacity for rapid evaluation of those public health actions and translation of that evidence into practice. Next slide, please. So for those that have been in the ARCFEST meetings before and in the Improving Population Health theme, we've got several different projects, many of which we've heard about in more detail in previous ARCFESTs. So lots of those projects are evaluating local interventions to improve population health and reduce health inequalities. So we've got eight existing projects, and many of those projects use linked routine data from the NHS and from other services. So we receive some anonymized data from NHS services, and we use that to try and understand what's working and which particular groups of people are at risk and what we can do to more effectively improve health and reduce health inequalities. So what we're going to hear about today is how we're using some of that data and how that data is linked and used in a safe way to protect people's identities, but how it can be used for great public health benefit. Next slide, please. So the sort of objectives for the session today are really to raise awareness about ways that the NHS is changing and how some of the organisation of the NHS is changing, in particular the establishment of these integrated care systems that you might have heard of. And particularly how linked patient data is being used as part of that to improve health, and how we're using that within the ARC in some of these projects. And so to hear a bit from you about how the ARC could better use patient data to improve health, and to highlight some of the projects that we're doing using this kind of data. So to start off with, we're going to hear from Wes Baker, who's a strategic director. You can introduce yourself, Wes, but Director of Population Health at Merseycare. Who's going to talk to us a little bit about how some of the organisation of the NHS is changing and how we're planning on using data to improve healthcare services within Cheshire and Merseyside. So Wes, I'll hand over to you.
Hi everyone, my name is Wes Baker. I'm Director of Strategic Analytics, Economics and Population Health Management at Merseycare. We're a community and mental health provider. We're the second biggest community mental health provider in Cheshire and Merseyside. And we cover geographies from Sefton all the way to Warrington. Can I have the next slide, please?
Can you see it, your slide? The slides are moving on.
Yeah. Oh, they're just not moving for me. It's not. Okay. I'm still seeing the original slide. Just bear with me. Oh, yeah. Yeah. Okay. Oh, I can see it now. Yep. So, sorry for the delay. So the current landscape, or the current NHS landscape, was based on a word that with the Landscape reform came up with, which is around competition. And this is an example of a Liverpool system where you have Liverpool Clinical Commissioning Group NHS England and Improvement, who is a regulator but also commissions some specialist services, and local authorities, which commission social care and some elements of public health. And they commission, and the funding then transfers to providers within Liverpool, like Merseycare, Liverpool Hospitals, Alderhay, GP and independent sector. But the key around this was centered around organizational autonomy, competition, and separating providers and commissioner split. Obviously, when you create competition, because the idea was competition would increase quality of care. I don't know if that's worked or not, but what it does do, it's in opposition to integration. Can I have the next slide, please? So the difference between the new arrangement is the commissioning groups, the clinical commissioning groups in England and Wales will be abolished. And there are 9 of them currently in Cheshire Merseyside, and those 9 will form a new body called the Integrated Care System. And the Integrated Care System will be centered around integration. So the difference between what we previously saw in the current landscape is around competition. This is centered around integration, and a lot of the contractual frameworks will be aligned to link into more integration. There's a lot more working around local authorities, so supporting local authorities as well to support population health, and that's a big requirement going forward, as well as working with other partners like the universities and doing further research and supporting that agenda. So funding still transfers it in this way. You'll find the difference is that NHS England and Improvement will change to being more of an oversight and regulation, because in the current landscape they do a bit of both of commissioning and regulation. So there was a disconnect. You can't be a commissioner and a regulator because you're marking your own homework. So the idea behind this is now that they will just be an oversight and regulator and handing all the budget to the integrated care system to work with the other providers. But the idea with the integrated care system, it works with the providers as one system. Although it commissions services, it is around and centered around integration. So that's the new landscape that's currently going through legislation, which will also shape over the next 12 months. Can I have the next slide, please? So something that we're working on in readiness to an integrated care system is a project that we've started called System P. It's a project in Cheshire Merseyside that we've been awarded funding of about £500,000 to start to do some work on 2 or 3 priorities and to build some pilot sites to demonstrate the power of kind of working in a system. And it's centered around kind of 4 pillars, using this link record, which we'll be talking about today with the other speakers. How we use the link record, and having a link record is really important to use to allow us to get the insights. The analytics is another component, because you can have all the data in the world, but if you don't have the data scientists, the analysts who can interpret that data and come up with different models of care and insights, that's not going to work for us. So we understand, and that we're very good in the NHS of doing some of the D and the A. What we're not so good at is the C and the P, which is coming up with different models of care and ensuring the payment then moves with that model of care, and we can sustain that going forward. And that could be not just looking at systems that are fragmented, but also on the prevention agenda. How do we ensure that funding moves towards prevention to reduce inequalities? More information on System P can be found at the top. It's just a breakdown, but all the framework is centered around this. So everything that the ARC's doing is probably a complement to this work. And that's it from me. Just passing over to the next speaker.
Thank you, Wes. Sorry, I was on mute there for a second. So yeah, that's how the NHS is changing, and people may have heard about how the different clinical commissioning groups that we had across the Northwest are all merging into these bigger organisations called integrated care systems. And as Wes has pointed out, a lot of the plans for sort of future work and better integrating services, so making services so that they're better suited to individuals' different needs, is to better use some of the data that is available and better linking that data across different services. So now we're going to hear from Roberta, who's the lead researcher for the Improving Population Health theme, about how some of that data does get linked and some of the issues related to that. Roberta, I'll hand over to you.
Can I have a new slide, please? So we see the sort of like linked data is data that is supposed to support the analysis to enable integrated care systems. And what I'm going to tell you in the next slides and what I'm trying to demonstrate to you is that with this data, we can build some pretty informative tapestries of population health. Why I'm saying tapestries, you know, in the past, and also some contemporary artists like Grayson Perry, they use tapestries with patches of different patterns of fabric, colored threads and embellishments to tell a story of what is happening in society. And let's see how we can do this with this new linked data. New slide, please, Sean. So linked data is based on the data the organizations routinely collect for the purpose of delivering care to a person. Each one of us may access care in different settings. So there are different places, like here in this slide, you can see that it's sort of like a hospital, a GP, mental health care. We receive care in the community, and we have contacts. We may have contacts with social care. So imagine each setting as stop moving. Imagine this setting is sort of like, it's like a box. It contains colored beads. The colored beads are sort of like the data, and each color is pertinent to a different setting. So sort of like, so each box contains data that is used for your care. And this data is sort of like is personal data like name, address, date of birth, and NHS number. So it's sort of like you see, for example, in the hospital, it collects a lot of data. Let's see the two people that have NHS number, XY and AB. And these people have had a heart attack in June 2020. They are two men, so they're aged 65. When we keep the data just in their own boxes, they are not particularly useful to understand how a person needs differs from one another. But this data, they don't need to stay inside their own boxes of a hospital. They can be connected to other boxes. And for example, here, XY, we can link him with this GP record in another box of green beads of a GP record. And we can find out that actually he had problems before his heart attack with high blood pressure, but otherwise was healthy and was living in a green leafy suburb. So next slide, please. Now it's sort of like after discharging it from hospital, we can see link in another box that it just got in the care of a specialized community team. And this was pretty successful. If you, next slide, please. Because in 12 months, it just continued this care in community services, and it didn't need to have any other hospital interaction. Next slide, please. So let's see the other person that had a heart attack, AB here. Now we can actually also connect, actually we find his data in two different boxes. We find the records both in the GP and in social care. And so from the GP records, we find out that actually had serious respiratory problems together with cardiovascular disease. And next slide, next. After being discharged, he got some reablement, so sort of like some other services in the social care, which unfortunately didn't prevent him, next slide, from being readmitted to hospital in the next 90 days. And as a result, he needed to be transferred to residential care because his needs have increased. So can you get me the next slide, please? So these are two people, two blue data points inside the hospital box, which looked the same if we looked just at the hospital box, but they're actually very different. Next slide, please. And if we look at each other box of data, for the data points of the colored beads, we have the same NHS number. We string them back in a temporal order to form a story. Next slide. Then we find out that each chain tells a very different tale, a tale of needs that are not the same before the heart attack, and of a recovery and outcomes that are very different. So next slide. So we can imagine that having all this additional context about the person helps to tailor their care in a way that better reflects their needs. And this is important, but we actually are in the business of improving population health. So actually, to make the most of what these data mean, we want to put them all together. Next slide. So we might discover that these two individuals, AB and XY, are actually members of two different groups of people living in the same geographical area. Maybe the pattern of need and the use of services of AB is more typical of a population of Liverpool and XY of Chester. New slide. So we discover these patterns, and if we can quantify the needs, then decision makers can act to provide the services that are proportional to the need of a greater number of people. So what is important about the data tapestry that I told you before? Well, for one thing, for richer, more detailed colors, what was the next? Many organizations need to share their data together. Otherwise, colors may be missing. For example, think if social care didn't want to share their data, we would lack all color. This speaks about what Wes has spoken about, organizations sharing across the boundaries for the resources. But what about the data, the individual data of the people, and what Ben said about keeping them safe and protected? The pattern in the tapestry may only be created with the presence of all the individual chains of color beads. All the individual chains are essential, even though they are masked by the overall pattern. And what it is that it allows the chains to be strung. So the thread is a code that is unique to each individual. Remember that I said that the NHS number allowed all the data pertinent to one individual to be linked? This is correct, but in the process of creating the linked data, the records in the boxes are changed so that they are stripped of all personal identifiable information. So we don't have a name, address, date of birth, the information is taken out. The NHS number is transformed into a unique code, which is called a pseudonym. And this transformation is done by an organization called Nhs Digital. So the linked data that are used by planners like the CCG or researchers like us never contain real NHS numbers or identifiable information. The people that use this data for planning or analysis cannot identify real people that data is about. We can only see a code which is needed because we needed to say that this data is about one person and not another. The reason why this code is called a pseudonym, and we're not saying that the data is completely anonymized, is that for the data to be anonymous, after the organization transforms it, like the Nhs Digital, it throws the key, so we cannot go back to the original data anymore. In the case of this linked data, Nhs Digital has the key, so it can go back to the data and update it if we need more information. But only Nhs Digital has the key and the rules to access this data. So the rules around which CCGs and researchers can access this data are very strict, and Nhs Digital controls that. So I hope this convinces you that this data is pretty safe and is put to good use. And now we are going to hear about one of our public advisors and her experience about working with research using this data.
Hello everyone, my name is Saika Ahmed. I have been working as a public advisor for 7 years, first for Clark and now ARC Northwest Coast. I would like to share my experience being a public advisor for the Network Data Lab. The Network Data Lab is a new health foundation initiative that will build a collaborative network of analytical teams across the UK. The overall aim of the Network Data Lab is to improve health and care services and reduce health inequalities. As a public advisor, I would say it is ever so important that the public, together with clinician and commissioner, to help the researchers to select the research question according to what is important for them to make a difference if we are able to answer the question, and B, help with interpreting the analysis, the results of the analysis. I think the Network Data Lab and the linked data is very important, And I can give example of the question that we are already dealing with. We have done work on the shielded population, but the next project with the young children is ever more exemplar of a question which cannot be answered without the linked data. Children and young people having mental health problems usually do not receive a diagnosis for many years, but there may be a lot of other contacts with health and care system warn that something is not right. For example, missing vaccination or frequent attendance to accident and emergency or even admissions. Some contacts with CAMS and some contacts with early help schemes in school. If the children are in care, this is a very worrying risk. So you can pick up and some signals everywhere in the data if the data is linked, so you know that this child or a young person is going through this trajectory. And it is the same person all these events relate to. So I think the linked data is very important. So it is an opportunity to improve population health. So I hope to continue being a public advisor, being a part of the network data lab. Thank you.
Okay, and with this video, we see actually what NHS itself has to say about linked data and how we use their data and how we keep it secure.
The NHS uses your patient data to support planning and research, like deciding where to provide new clinics or GP services, or, as with the COVID-19 pandemic, informing guidance, government response, and vaccine planning. Nhs Digital is the part of the NHS that collects, processes, and makes data available to improve everyone's health and care. And we're making improvements. We're simplifying processes, reducing the burden on general practices, and allowing them to focus on patient care. We're also improving data security. You can always opt out if you like, but we make sure that your data is only used to improve health and care. And we will never share it for marketing or insurance purposes. We hold your data securely and depersonalize it wherever possible. And we only share it with trusted NHS and research organizations who will use it for the benefit of health and care. So you can take pride in knowing that your data is helping to make us healthier. For you, your family, your friends, and your future.
Thank you. Thanks, Roberta. Yeah, sorry, did you want to say anything about this?
Like if you also want to sort of like, you can also go directly to the NHS Digital, and sort of like there's a lot of more information about transparency and the security of the data and how we're using the different linked data. Back to you, Ban.
Thanks. So, you know, we've heard an excellent description of how data is linked and what that helps us do. So now it's a chance for, if there's any questions from you about kind of what do you think about how these data are used for research? How should the NHS and other users of the data that we've heard about, how should they involve the public in using that data? How should they decide on how data is used? What other protections do you think should be in place? And what information would you like about how data is used? So really it's just a chance for you to, anyone to comment on things that they've heard and to help us think about how we can better involve the public and people across the Cheshire and Merseyside in using that data. So if there's anyone, if you want to post any questions in the chat, or if you want to unmute and ask us any questions, that's also good.
I would like to know sort of like how many public advisors, members of the public, are in this session around here. We have Saika, Sinhina. Anybody else?
Yeah, I'm a public advisor, Nahid.
Hi, I'm Iram Durrani. I'm a public advisor as well.
I'm Paul Marlow. I'm a public advisor.
Hi, do you have any comments sort of about this kind of data concern?
I wanted to ask, what is it? Have you found anything in the research that is about the barriers that are stopping people from sharing data? Why are people so reluctant?
So do you have the impression that people are reluctant to share data?
Yeah.
Yeah.
That's the impression I get, and the impression is that the more you hear about it, the more reluctant people are, that they want to share.
Okay, so you think that the
Your
more
presentation, rather than it's put me off rather than giving me the confidence to share it. That's just my impression. So I'm just wondering what your research is showing.
So our research, we are sort of like we are trying to do a little bit more engagement, and that's sort of like the reason why sort of like we're starting. We've done something in previous ARCFEST, and we would like to get more feedback from people like you, and I feel that sort of like as researchers we haven't really sort of done that much in terms of communication and sort of, and in terms of sort of like how this data is kept safe and how this data is used. So we couldn't really sort of like answer. We would like you to tell us what is concerning so we can address. Why do you think, what made you feel more reluctant, if you want?
Roberta, maybe I could come in there. I think Peter also raises an issue about in the chat about where do private or for-profit care homes sit within the system of data gathering. And I think, I mean, one of the things that has been raised in the media, I think, around this issue has been concerns about private companies getting access to NHS data and using that. Sorry, someone's typing very loudly. I think it might be Selena. If you can mute. So yeah, people have been concerned about private organisations having access to patient data is one of the concerns that that people have. Is that something that you have identified as well?
Yeah, I have identified that as well. You just see, you know, things like fake emails and things. You suddenly do something, or you might have filled in a questionnaire or something, and then you suddenly, there's an influx of emails, cookies. So
yeah, I mean,
recently I have done some of that, and I've been inundated with emails from Microsoft, which are obviously fake, but it's that one time that you don't realize and you click.
Yeah, I mean, there's so much data of ours, particularly being used within sort of social media and Google and other kind of online services, where a lot of you provide one organization with information and it goes to other organizations, and I think that is definitely a concern. I think the restrictions within the NHS and how NHS data is kept are far stricter than anything else you would find within within kind of commercial uses of data, and it's yeah, and they have, you know, as Roberta and others has outlined, there are very strict conditions under which data can be used, and if a third party using the data, like, you know, external organizations like university using that data, where it's not possible for us to link that to other data sources that we might have. So it wouldn't be possible for us to do that in a way that that would mean yeah, that data could be used in any way that isn't basically for the research purposes that we initially agreed to using that. There's some other points in the chat. There's a lot of mistrust. Yeah, I mean, I think it is really about trust, and I don't think the NHS has necessarily always done the best job in explaining to the public about how their data is used, and how it can, you know, have huge potential for some public benefits, but you know, there need to be much clearer, I think, and I think we need to think about how we can better involve how that data is used, and getting a greater understanding of the protections that are in place. So there is quite a lot of misinformation about some of the risks related to this also going around on the internet. So it is really about being clear about being clear about that and building trust with communities in how their data is being used.
Yeah, definitely. I agree with you there. I think the ARC is in a prime position where we can improve communication and understanding of data sharing. I just feel from my position that where it should be used and where it should be shared, it's not being shared, and where it shouldn't be, it is. But yeah, definitely the horse's mouth, I think. From, you know, we should be predominantly emphasizing advantages.
Yeah, no, I think that's exactly right. Yeah, in lots of cases, I mean, we have to go through lots of hoops to get access to the data that we need, and sometimes that can be quite frustrating, the levels that we have to go through. And you know, we were trying to get access to data in the middle of the pandemic in order to help inform the local response, and it's taken, for some of that, it's taken kind of 8 months to actually get that approved, which isn't necessarily how you want to have it, in order to be able to respond immediately to the issues that were being raised during the pandemic. But equally, it's clearly very important that all the right procedures are gone through to make sure that data is secure. So we've got a few more comments. Peter, did you have something? You posted a few things in the chat. Did you want to make some points about how private providers of data, both, you know, potentially providing and using data, could be helped? So I think, so Peter, there's a question, I think, about how private care homes might, at the moment, so one of the things that we don't really have much data on is actually data from private care homes. And one of the things that we've been looking at as part of the ARC is to try and understand things like vaccine uptake in care homes, and how that, both amongst the patients and the staff, and yeah, how that relates to kind of risk of outbreaks in care homes. And one of the problems that we've got is actually that we don't really have very good information. It's hard enough to actually just identify who are residents in care homes within the data, and even harder to identify whether people are members of staff within care homes. Okay. Sorry, Roberta, do you have something?
Sort of like, because we have this question, which I think, what protections do you think we should be in place, and what information? And it's sort of like, would it be a fair summary of what we are saying? That is sort of like, what you think it's important is to have transparency about which organization actually have access to the data. Would it be something positive that can be done to enhance trust?
Is that a question to me, Roberta?
A question to everybody who thinks sort of like, if anybody wants to unmute, sort of like, I feel that there's sort of like a lot of the questions about who has access, how transparent are we in sort of like in who has access, because it's sort of like.
Can I come in, Ben?
Yes, please, Mark. Yeah.
Please.
I mean, I've put a couple of comments on the chat, and I'm familiar with this debate from the medics, and GPs in particular are very uncomfortable. And I think it's nothing to, as far as I'm aware, it shouldn't be anything about the security of the data, the ethics and everything else that you've been talking about, and the systems. They're very robust. It's about what NHS data will do once the data is available, and who they will allow access to, and under what terms and conditions. So, for example, if they said to commercial providers, you're welcome to come and use the data to develop AI, etc., for the benefit of the NHS, but then we expect you to sell us the services back at cost or on a non-profit basis. But I'm not aware that they're planning to do anything like that. And I think that's why some people have some misgivings, because of the reasons I stated. Their concern is that we will be sold back software, for example, that's been developed from these huge data sets for artificial intelligence, but at a cost, when in fact it was only developed because of the access to the data that was provided either very cheaply or free by the NHS.
So, yeah, I mean, I think we'll probably need to move on to the next session, but I think there are two things there that have come up in the chat as well. So there's the issue that Mark's raised about, data is valuable. Yeah, and this data does belong to the public because it's the public's data. So there is ensuring that the benefits of that data, basically, and that includes economic benefits as well as benefits directly to patients, go back into the NHS and are used for public benefit. And then there is this issue, I think, as being clear as to who and why is using, which organisations are using the data and why. And NHS Digital does have a registry of all of the people who they've given access to. They could be probably more clear on that. But where we're working locally, and I think the thing that Peter suggests about local data trust, that's exactly what we're trying to develop locally with all the organisations across Cheshire and Merseyside, as linked to the integrated care system, and to build that sense of community ownership of that data, and ensure that there is public accountability for how that data is used. So thanks. There's some brilliant ideas there, and we'll save all the things that you've put in the chat that we didn't manage to get to, and use that to think about how we can do this differently as we're going forward. So we'll just move on now to some examples of how we've been using this data for research, and starting off with an example of how we've been using it, particularly the vaccination data, to help target support for vaccination uptake across the Cheshire and Merseyside region. And Nhs Zhang, who's been doing this analysis, who's a data scientist working with the NIHR Health Protection Research Unit in Liverpool, is going to tell us a little bit more about that. Nina.
Hi. Hello, everyone. So, the presentation that I'm going to do is based on the CIFA data. So the CIFA data is the combined is obtained from the Combined Intelligence for Public Health Action program. From this slide is taken from the web page of the Cheshire and Merseyside. You can check the web page if you are interested. So the CIFA program covers roughly 2.7 million people. It includes 9 local authorities, which covers. It also covers roughly. It covers 1,562 LSOAs. LSOA is commonly used geographical unit in the UK. So its full name is lower layer super output area. And so in each LSOA, on average, it covers roughly 1,500 people. So all the analysis I'm going to present are based on this scope. Next slide, please. So I want to share with you our finding regarding the interaction between age and deprivation in terms of vaccine uptake. So this slide shows the x-axis is the different age groups. The y-axis is the crude uptake rate. So the unit is percentage. Different colors represent different IMD quintile. IMD is the index of multiple deprivation. So from this chart, we can see the relatively younger age groups between 40 to 50. So the gap of crude vaccine uptake, the gap is actually wider among these relatively young middle age groups. And so our understanding is actually the gap is wider among younger age groups, but because people under the age of 40, they have only got access to the vaccine a very long time ago, so we're not able to see the gap to play out fully actually. So that might be a reason. Next slide, please. So this chart shows the relationship between vaccine uptake and ethnicity. The x-axis is the weight number. The y-axis is the age-adjusted accumulated uptake rate. So the major difference between age-adjusted uptake and crude uptake is whether to take into account of the overall age distribution and age distribution across the CIFA region. The different color represent different ethnicity groups. As we can see with the rollout of the vaccine program, the gap of vaccine uptake among different ethnic groups, the gap is actually getting larger with the rollout of the vaccine program. Next slide, please. Similarly, we can observe the gap of the vaccine uptake is also getting bigger. it's also getting big among different deprivation groups. In this chart, different colors represent population of different deprivation levels. Next slide, please. So this slide shows the vaccine, the spatial and temporal patterns of vaccine uptake and deprivation. On the right-hand side, it's a map of deprivation, an index of the quintile of IMD. So it's relatively stable. So it is shown here as a static map. On the left-hand side, it is a accumulated crude uptake of the weeks. I use the same coloring scheme to be more specific. The yellow represent lower vaccine uptake, and also it also represents the most deprived areas. So you can see there's a very high correlation or very similar pattern with regarding to the lower vaccine uptake and also the higher deprivation level. Next slide, please. This map shows the bivariant relationship between case rate and crude vaccine uptake. Here, we calculate the case rate as the active cases in the past 28 days, in the past 4 weeks. So this data is taken by June 15th. So it's based on June 15th. With the darker colors, dark green represent places with lower uptake but higher case rates. We can see, for example, in Liverpool, city center of Liverpool, we can see many communities and neighborhoods with higher case rates but relatively lower crude vaccine uptake. So in that way, it can help us to identify places that are at higher risk, so we can deploy the vaccine program accordingly. Next slide, please. So we are also using the CFA data to inform us regarding the evaluation of the vaccine bus program. So we use the CFA data to get the overall pattern of the vaccine uptake, and then the middle map shows the location of the vaccine buses in Liverpool in the past few months. So we are going to treat LSOAs nearby vaccine bus site as the intervention areas, and all the other LSOAs as the control areas. In that way, we can use the synthetic control modeling to quantify and to understand how much difference the vaccine bus has made to the local community and in the short term or in the long term. That'll be all from me. I'll pass it on to the next speaker.
Thanks, Nina. That's back to me. So a really good example of how we're using that data linked data across the population to better identify those areas and communities that have particularly low uptake, and then we're then using that to target these mobile vaccination units to those places, and then we're able to estimate whether that's actually making a difference to uptake. So whether it's leading to new people being vaccinated that wouldn't have been vaccinated otherwise, that might have gone to other kind of static sites. So this final example is going to give is a new project that we've got called Restore, which is for research for equitable system response and recovery, a new funded project from the NIHR that's all about trying to use linked data to better identify people at risk during the pandemic, but also more generally, and evaluating whether that makes whether intervening in those groups, providing them with new services, whether that makes a difference to levels of risk. Next slide, please. So we've sort of got two elements to it. Can we better use this data to identify adults and children that are at risk early, and then understanding what works to reduce those risks and improves outcomes in those groups? And we're looking at that across a whole range of different outcomes for both adults and children. So things like emergency hospital admissions, development of mental health problems, referral into children's care, social care services, whether children are ready for school, and things like school absence. Next slide, please. So why is this needed, in particular for the work we're looking at that Saika also mentioned on children, trying to identify risks in children early? This is hugely important because at the moment, particularly in Liverpool, child health is going in the wrong direction. We've got quite a large increase in infant mortality since around 2012. We've also got this increase in children being taken into care. And one of the most sort of worrying bits about that is because over the last decade, or since 2012 at least, we've actually seen a decrease in spending on prevention services in children, at the same time as we've seen an increase on public spending going on taking children into care. So we've got potentially things going in the wrong direction at the moment, and we want to try and use the work that we're doing to change that around. Next slide, please. And as others previously, Saika and Roberta explained probably better than I can, we want to try and identify the trajectories of these children early so that we can intervene earlier. So if we have data on the whole population, we can start then to look at which groups, what patterns are we seeing in the data that can identify groups that are at risk. Some of those that are at risk then go on to have an adverse outcome. So that could be something like an emergency hospital admission, or dying early, or children being taken into care. Some of those people will need services, and a portion of them, hopefully a large proportion, actually get the services that we need. But we can only really look at that whole trajectory across the whole population if we have this linked data. And with that linked data, we can then identify groups that are at risk early, looking at those patterns in the data. And that means we can intervene more upstream to prevent those outcomes happening in the first place, rather than just dealing with the problems further downstream when people are already in services or using services. Next slide, please. And the second part is then when we've got sort of tools in place that can help identify people early, then obviously there needs to be a response to that from public services, providing the kinds of sort of integrated care and support that Wes was talking about. But using this data, we can then look at whether intervening in that way actually makes a difference. And this is just some work that we did looking at multidisciplinary teams, so teams involving lots of services getting together and trying to develop better integrated care for people that were identified at high risk of hospital admissions, or emergency hospital admission. And that approach we found actually didn't have a big impact on reducing those people's risk of hospital admission. And we also found that it didn't have a huge effect on reducing their mortality, so their chances of dying after receiving the intervention. So we can use this kind of analysis to identify the things where things don't seem to be working in the way that was planned, so we can better invest that money or adapt those services to ensure that in the future they are having the kind of impacts that were aimed for. So this is part of what's being called a kind of learning health system, so we can test things out, see whether they're working, and rapidly adapt them to produce better outcomes. Next slide, please. And linking back to the work that Wes was pointing out, the way we best do that is to work really closely with our NHS and local authority colleagues and pool our resources around the kind of skills and things that people like Nina and others have, and Roberta to work in joint teams with analysts in the NHS and local government to rapidly turn around this kind of analysis. And that's basically what the System P program that Wes mentioned is all about, trying to get those teams working with that data to better identify people at risk, develop services to intervene to reduce those risks, and evaluate whether that's making a difference. Next slide, please. So that's just a couple of examples of how we're using this kind of data to try and improve local services and address improve health and reduce health inequalities. So there's a chance really for any more thoughts that people have about, what kind of things should we be prioritizing in this kind of analysis. As we pointed out already, some of the things that have been prioritized by the local system have been in particular looking at children and trying to identify children at risk, particularly at risk of being taken into care, but also lots of work amongst sort of older people, particularly people with very sort of complex conditions, and trying to identify those, but also a focus on sort of mental health. So any other thoughts before, in the last, we've got sort of 9 minutes left of the session. Any other comments or thoughts that people have on areas that we should be, that people feel we should be looking at, or any thoughts on any of the presentations that you've heard today? There's still quite a lot of chat about the data protection issues, which we could also get back to. Any other comments on Selena? Selena, do you want to ask your question? You posted something there about the ACEs tool, which I think is an interesting one.
Yeah, I've just heard people having concerns about the target interventions at people, and as a way of sort of linking people to outcomes rather than using it in a population sense. There's been people, and I've also posted a link to a blog I wrote a couple of years ago about modeling, using modeling techniques to try and type people into risk interventions around putting children into care as well. So that might be useful.
All right, that would be very useful. Yeah, so I think your first link, just so people, the ACEs is gone blank as to what the acronym stands for now. Adverse childhood events. That's it.
Experiences.
Which is experiences. Sorry, adverse childhood experiences. Which we know that trauma and other other adverse experiences in childhood have huge effects on child health and track forward into adulthood. And there has been a sort of movement around that, which has been referred to as ACEs, although it's kind of evidence that's been known for a long time about the effects of childhood experience on later health. I think one of the things, I think the issue that Celine was raising is kind of using that as a tool to sort of screen people for experiences they may have had in the past, and trying to then use that as a way to inform services now. So actually, sort of screening adults basically to identify people who have had adverse childhood experiences. And I think there are quite a lot of issues with that, and I think clearly what needs to be done is preventing those experiences in the first place, I suppose, which is some of the work that we're trying to do here, really, is to better identify those things earlier, because there is a lot of debate about whether, knowing that someone had those experiences in their childhood, whether that's actually beneficial or not in terms of targeting services. Exactly, as Neil said, it shouldn't be used as a diagnostic tool, and I think that's definitely right. Although there definitely has been some of that happening, I think, of using that kind of screening as a way of sort of intervening after the fact. So Ruth has raised an important issue about information about children from schools. And I think that is one of the issues that, because at the moment we don't have very good linked information between the education system and health. We have some information from social care, but most of the early identification of risks that potentially track forward later in life is going to be through schools, and that's where things are picked up early, and better use of that data and information could potentially be much more effective at identifying children early. Yes, any other thoughts on things that we should be focusing on for the future? It seems like there's a lot of interest in work around children in particular, and that is something that we feel is important. It is also one of the areas where some of the data is not as good as it could be. We usually only have quite a lot of limited data on children who are receiving support, but it's definitely an issue of trying to get information about children earlier on in their life course. And I think the point that Ruth makes about better involving schools in this, I think, is really important. And we're starting to work with the education department at Liverpool City Council to see how we can better use some of that information to identify children early who may be having problems. But of course, the services need to be there to actually do something. There's no point identifying problems or identifying risks if we haven't got the resources to put support in place. And one of the problems, and what we've sort of already seen with the way the sort of funding for children's services has been going, is that a lot of that support has been taken away. So using this evidence to better make the case for shifting investment to the early years and children is going to be crucial for addressing health inequalities. Okay, so I think that's the end of this session. We've reached the end of our time limit. So I'd just like to thank you all for attending, and thanks so much for your input. I think it's been a really interesting session of understanding some of the ways, and it's definitely helped us think about some of the ways that we're using this linked data, how we could better sort of involve the public in that, and better communicate about how we're doing that, and how it could be used, and getting some ideas from you about how we can better build collaborations, and moving, as Hayley has pointed out, some of this work has been focused in Liverpool, and we're really keen on how we can better engage other areas in the Northwest Coast in that. So building some of those collaborations, and if you've got any thoughts for how or any connections that you think would be useful to bring into this work, both sort of from yourselves and from others, please do get in contact with us, and we'll work with you to work out how you can get involved in these programs of work. So thank you very much, and we'll hopefully see you at the next ARCFEST.